All right, I have 11 o'clock. Good morning, everyone. We're going to get started to keep this train rolling on time. Contrary to what my window says up on the screen, I am not Kimberly. I am filling in for Kimberly today. Kimberly is unable to join today's webinar, but I will fill in. My name is Eric Heisler. I'm the Director of Communications here at PHCA. I do have some notes and some brief remarks to give you before we jump in and turn the presentation over to today's presenter. I want to thank you for joining us for today's webinar. Just a reminder, as you heard just a minute ago, this webinar is being recorded and will be made available on our website following the webinar. The webinar has been approved for one continuing education credit for all PHCA members in attendance. For those who provided a NAB number, credits will be uploaded shortly. We'll also share certificates with those in attendance. We will begin today. As we begin today, all attendees will be in listen mode only. Please feel free to submit your questions via the chat feature. You'll see the icon for chatting at the bottom of your screen. Submit your questions there, and as we are able to, we will take your questions or collect them and give them all to Eileen at the end and give you answers at the end of today's webinar. I'm now going to turn it over to our presenter, who is Eileen Warner-Marin, the Assistant Professor in the Department of Geriatrics and Palliative Medicine at the Philadelphia College of Osteopathic Medicine. That's quite a mouthful, Eileen. She is today's presenter, and I will now turn this over to Eileen. Eileen, thank you for joining us today.
Thank you. Thank you all for joining as well in this presentation. It's my hope that this presentation will provide another source of information so that facilities like the ones that you're working in can provide the best quality of care to patients. And what we see across the board is this interest in using technology, in using pharmacology, and in using evidence-based knowledge in order to improve the way that we deliver care to our residents. I just wanted to start by just saying that I've been working in long-term care facilities since I was a teenager, and as you can see from the video, I'm far from a teenager anymore. So I began in the 1970s when we didn't even have nurse aid training programs. It was just you would be buddied with another aide, and if that person had good skills, you would learn those skills, and if the person didn't, then you would learn their bad skills. So we've certainly come a long way in the last 45 years since I've been involved in long-term care. And so we're always trying to figure out, well, what is the next thing that's really going to help us? And that's really what I want to present with you today. So here are the goals of the program. And again, I want you to try to see if there are things that you can identify for yourselves that will help enhance the care of your residents, especially by identifying ways in which we can prevent or delay the transfer of people to the hospital, as we used to always do. Somebody had a seizure, immediately they were sent to the hospital. Sometimes that was not a very helpful thing, in that it just delayed getting the actual treatment for people. And the treatments that we had back in the 70s, 80s, even 90s, I think, just Dilantin and phenobarbital, without really having any rescue medicines that were available in the nursing home. Those things really limited our ability to treat people. And so we'll look at the things that now are available to us. We want to also look at the advantages as well as the disadvantages of using rescue medicines for the treatment of seizures in the skilled nursing facility. We specifically want to look at how a seizure action plan can be used for the treatment of residents with active seizure disorders. And we also want to consider what other diagnoses might lend itself to a similar kind of action plan. For example, for heart failure or for hyper or hypoglycemia. How else can we think about using an action plan like this? So just to review, a seizure is defined as a sudden, uncontrollable body movement with changes in behavior that occur because of the abnormal electrical activity in the brain. And I explain this to patients by saying, if you think about your house and you blow a fuse in one part of the house where the electricity isn't flowing to that room, but is flowing to the rest of the rooms, you kind of equate it that way. Symptoms of seizures include a loss of awareness, changes in emotion, loss of muscle control, shaking, may also include having incontinence. Seizures may be caused by all kinds of causes, drugs, fevers, head injuries, diseases, and specifically epilepsy. But we increasingly see this as an issue in people in long-term care settings. According to the CDC, about 3 million adults in the United States over the age of 18 have seizures. And 56% of adults taking medications for epilepsy still continue to have seizures, which is a big problem for us. Even though we're administering the medications as ordered, even though we're looking at drug levels, we still have people, the majority of people, to continue to have seizures despite being administered the medications. The average total cost, direct cost for a person with epilepsy is between $10,000 and $48,000. And so when we look at the cost of an ER visit, it's going to be usually between $1,000 and $4,000, plus the transportation to the ER and any other kinds of issues that happen. And for example, when people are given a lot of Valium to try to break their seizures, if they're in status epilepticus, they may overshoot on that drug, and the person ends up in respiratory failure, needing to be intubated and placed on a ventilator. Also, we're really concerned about our quality indicators, and going to the hospital as a short-term quality indicator or a long-term quality indicator could really be a negative issue for us. So the CMS defines short-term ER visits for our short-term patients as the percentage of people who have to go to the ER. For the long-term residents, it's the number of ER visits per 1,000 residents in the long-term care setting. So we can be really hit negatively on the transfer of people to the hospital. I'm not suggesting that we not transfer people, because if they need to go, they're going to go. But if there are ways that we can treat people in a setting where the staff know them, where they feel comfortable, where they can be supported and appropriately treated, then that might be something that we should consider rather than sending people to the ER all the time. So in the United States, seizures occur in about 1.2% of the general population, but we know that the incidence of seizures increases with age, and the incidence of seizures is highest in a skilled nursing facility, higher than any other kind of setting that we know of. So the proportion of skilled nursing facility residents with a diagnosis of seizures is seen to be 7 to 8 times higher than compared to people who are living in the community. So we have a very, very large concentrated proportion of people in long-term care facilities that have a propensity to have seizures. And then lastly on this slide, 22% of hospital admissions for the treatment of seizures came from residents from SNFs, as compared to only 1% of people who are community dwelling. So, so we have large numbers of people being admitted and readmitted to the hospital for these kinds of issues. And we want to really try to see if we get a handle on some of this. So here are some of the causes of seizures in older adults. And hopefully by the time the resident is admitted to the long-term care facility, we're not going to see people in active alcohol withdrawal. But there are increasing numbers of older people who are actively drinking. We see that since COVID, there's an increase in, across the board, but increased especially in older adults. And the treatment for alcohol withdrawal is to be able, number one, to identify who's drinking, and then to be able to give benzodiazepines to prevent those alcohol withdrawal symptoms. I worked in an alcohol detox unit when I was a relatively new graduate, and we would just continue to give um, um, uh, Librium very liberally to the residents, to the patients, so that they wouldn't have these alcohol withdrawal symptoms, which can be frightening for the person, and they can also lead to death. So I also found that when you ask people how much they drink, sometimes they don't always tell you the truth. I've had patients who say, I only drink 1 glass a day. But the truth is that they just take that 1 glass and just keep filling it up. So sometimes, as part of the disease of alcoholism, people are not honest about how much they drink, and that should be expected. You may see people having seizures from heat stroke or febrile seizures. We see that more in children, but you may also see that in older adults. When people are severely hypoglycemic, with very low blood glucose levels, you will likely to see the seizure, and as well as the lack of consciousness. Any kind of things that will affect the blood chemical levels, the sodium chloride or magnesium levels, whether that's medications or the depletion of these electrolytes and chemicals in the bloodstream from a host of medical issues. Traumatic brain injury is one specific kind of cause that you see very frequently. You may see it in people who have had car accidents, or people who've had been victims of crime. For many years, I was the guardian of a young man who had multiple traumatic brain injuries as a consequence of a drug issue, of being in car accidents, of being beaten by other people. And unfortunately, he had absolutely no memory. He could barely even tell you his name. And he had an active seizure disorder. He eventually went to a long-term care facility and was constantly being transferred back and forth from the nursing home to the hospital, back and forth, and really didn't get much of a benefit out of that. Of course, we didn't have those kinds of rescue medicines available in long-term care at the time of his residency. You may see people with brain infections, meningitis, brain tumors. The seizure that a person presents with, a new seizure, is usually diagnostic of a person with a brain tumor or a seizure from a stroke. So strokes are a major cause also. Anyone with impaired kidney or liver functioning because of the changes in blood chemistry, those people are more likely to have a seizure. And then any of these medications that we use pretty frequently, antidepressants and stimulants, people who are using street drugs like cocaine and meth, even diphenhydramine, tramadol, and isoniazid, which we use for tuberculosis. So a host of medications could be the cause of seizures, and we really do hope that our pharmacy consultant will be able to identify these kinds of issues for us. So people have seizures, and there are a number of things that can happen to people as a consequence. And what we know is that it generally increases the morbidity, which is sickness, and mortality, which is death, of people who are experiencing these kinds of seizures. The mortality and morbidity are associated with harm that occurs when people are having a seizure, if they're driving or if they're walking and they suddenly start to have a seizure, if they have a respiratory event as a consequence. So we know that these kinds of things increase the risk of illness and death. I've had many cases in which I've been asked to look at lawsuits involving people who have fallen. And I find it really interesting that there are cases in which people were sitting in a chair without any trouble at all, who never had a history of falls, and then they were found on the floor. And so if they had a history of seizure disorder, perhaps it was not that the staff weren't attentive to their needs, or that they were sitting too long, but instead they were experiencing a seizure. We also see that there is a risk of brain damage from prolonged seizure activity. And so you may see that the cumulative effects of people who have multiple seizures have this negative effect at the very end, where people have extreme issues with their cognition and with their functioning altogether. Again, the risk of death and the risk of what we call status epilepticus, which is when people have one seizure after another after another. And this is really an emergency in which we really have to break that seizure um, that seizure risk. So generally, we know that there's an emergency treatment for residents experiencing seizures. And you may actually have seen this kind of issue when you're out and about. I was in a diner, and the hostess, who was faced with a huge line of people trying to get in on a Sunday morning, had a major grand mal seizure right in front of all of us. So going to her, placing her on her side, and not restraining her, just making sure that her airway was patent so she's not on her back. And then just trying to keep note of what part of her body was affected by the seizure, how long was she unresponsive, did she lose bowel and or bladder function, and how long did it take for her to emerge from the seizure. So those are the kinds of things that we try to do. But if the person is cyanotic, or they have a low pulse ox, or if the seizure is really going on for longer than 5 minutes, despite our efforts to use rescue medications, then the person probably will need to go to the ER. But family members may be afraid that their family member will be swallowing their tongue. It's not physically possible, of course, to swallow your tongue, but it is possible for the tongue to be blocking the airway of someone who's experiencing a seizure. And for that reason, we put them on their side. So I don't know how many of you have heard about the Seizure Action Plan, which we call SAP for short, because in healthcare we have to abbreviate everything. I don't really know why. But the Seizure Action Plan is used to identify who may have a seizure, what the staff should do, what the goals of care are, making sure that the family, the physician, the resident, and the staff are on the same page about the goals of care, and trying to see if there are ways to prevent the transfer of that individual to the hospital, if at all possible. So here are some of the most commonly seen rescue medications. So there are three. There's a rectal route. It's a gel of Valium or diazepam, which is the generic. And that's been around since 1997. It takes between 2 and 10 minutes for it to start to work. And that should be shelf life, I'm sorry. The shelf life of that medication is 2 years. So one of our considerations is frequently how long will how long will we be able to store this medication, and how much will it cost? So this medication is relatively inexpensive. It's about $45 per per treatment. So it does then require that if the person's having a seizure, we have to get them into bed, or be able to get them into a situation where we could administer the medication rectally. So we have to get to their remove their lower extremity clothes in order to administer the drug. Can administer it in a large volume, and it is 90% bioavailable, which means that most of the medication will be able to be accessed by the body. The disadvantages of using rectal gel diazepam are that it may be inconsistently absorbed depending on how much stool is already in the rectum. Again, you need to remove the clothes in order to get to the rectum for the administration. There's a potential that you put it in and it unfortunately leaks out. And if the resident is already taking opioids or benzodiazepines, um, or other kinds of CNS, the central nervous system depressants, it may actually make those medications last longer, the actions be longer. So there are some considerations depending on what other kind of medicines are already on board in that particular resident. The other medications include intranasal midazolam, which you may know in the trade name as Versed. And this one is also has an onset of 2 to 10 minutes, and has a shelf life of about a year. The advantages are that it's really quickly absorbed, and you don't need to, of course, undress the person. Unfortunately, this nasal spray, midazolam, is only about 44% effective, bioavailable. So you don't get as much through that delivery system as you would normally. Now, a third one, which I don't know why is not appearing on here, unfortunately. The third way to do this is an intranasal spray of diazepam, so a Valium nasal spray, which was actually approved by the FDA in 2020, and has a shelf life also of about 24 months. And it is a lot more expensive. It's about $680 for a carton that has 2 nasal sprays in it. But that one is about 97% bioavailable. So for some people, that might actually be a better choice. So depending on the situation, depending on the medications already prescribed for an individual, we may be able to administer a nasal spray or a rectal drug, a rectal gel, in order to break those seizures. I should also add that the midazolam cost is about $695 for 2 packages. So we're not talking about a cheap intervention, but these drugs are certainly a lot less expensive than calling the ambulance and having the person go to the ER. So there are advantages to not transferring a person to the ER. the biggest thing probably is that by the time the ambulance comes and actually takes the person to the ER, and they actually hit the door of the ER and they're triaged in the ER, you're experiencing a particularly long delay that's not going to be very helpful for that individual. So these medications may actually provide a better rescue in terms of the timing of what we do in terms of our intervention. Cost, as we said, the psychological stress of going back and forth to the ER. And of course, we never know how busy that ER is going to be. And sometimes older adults are not prioritized in emergency rooms, as you probably know. So what is a seizure action plan? It's an action plan formulated with specific interventions for a specific resident. So if you're going to talk about individualized care or resident-centered care, this is it. This is a way of identifying the goals of care, the treatments, and being able to communicate that with the staff. It provides acute and daily treatment information. It focuses on what we're supposed to do in the post-acute phase of care in order to know how to manage that resident. It provides concise directions for staff. It directs which rescue medications, if any, should be used. And it helps us to try to predict the unpredictable. It helps us try to control what is very difficult to control. So having that information, sharing that information with the staff, with the family, and the resident can really be helpful. And when I say staff, I mean all levels of staff, the CNAs and the nursing staff, as well as any other professionals that are in the building. So approximately 70% of people with epilepsy don't have a seizure action plan, even though we know that these can be really helpful for all patients and residents. So I want to go over the seizure action plan. It's actually a one-page piece of paper that has different parts to it. So for my purposes, I've broken it up into different parts just so you can see each part at one time. So I want to show that to you. Okay, so this is the first part. It's the Acute Seizure Action Plan. You'd put the name of the resident, their date, birth date, and today's date, of course. And if you know what their normal triggers are, if they have an aura, then you can put that down as anything that sets people off. So sometimes people say, before I had my seizure, I smelled something burning, or I saw a bright light, or a glow around the light, something like that. If that's a trigger for a resident, it's really helpful to know. If you're able to identify a pattern to their seizures, a particular day, a particular time of day after the medications have worn off, or some kind of issue, and then that helps to have a pattern. So the bottom part of this actually talks about different kinds of seizures that you may see people have. So the first one is an atonic seizure, or a drop seizure, where the person suddenly loses consciousness. I was in nursing school with a woman who would just suddenly fall asleep in class, and we thought, well, I guess she's bored. But it turns out that she actually had an active seizure disorder. Now, she told me about her active seizure disorder as she was driving me down the highway going around 65 miles an hour, which didn't really help me very much. It scared the bejesus out of me. But her atonic seizures were caused by her being in a car accident and having hit her head. And so she didn't have anything other than she would suddenly lose consciousness. No um, um, uh, um, tonic-clonic movements, nothing like that. She would just look like she just fell asleep. Another kind is a petit mal seizure, where you may see somebody just kind of staring or blinking really fast, and or having this blank stare, and that is also considered seizure activity. You may have someone who just kind of loses consciousness. They become really stiff, rigid, and incontinent. That is a tonic seizure. You may have someone who also loses consciousness, is blinking, is having jerky movements, and that would be consistent with a clonic seizure. And you may also have someone who's got a complex partial seizure that has a blank stare and just doesn't really have the wherewithal to know what's going on with them. So it's really helpful to check off what kind of seizure we know that this person has, so that the staff can be aware of these kinds of abnormalities in that resident. In the second part, we have, it's called the green section, where the staff will look at the length and time of the seizure and make sure that people are safe. So these are the kind of the general interventions that we talked about earlier, that if a seizure happens, this is what we want to do. We want to make note of the time. We want to put the person on their side, move furniture or other objects out of the way, so that if they're having a clonic seizure and they're moving about, they're not going to hurt themselves. This may happen in in the bed, so for this reason, we want people to have padded side rails. It's one of the few reasons for the legitimate use of side rails in long-term care. We don't want to hold people down, because that will end up hurting them more or hurting our staff. We stay with the person, and then we maintain a record. So this is something that we would do for all of the residents who are experiencing this kind of issue. The next part is the yellow part, that if a seizure does occur, what rescue drug should we give, if any, and what is the method for which we're going to give it? So again, we have the diazepam rectal gel, we have diazepam nasal inhaler, and we have the Versed nasal rescue as well. And we may have some medications that we would give by mouth, which is much more difficult, of course, because we may have somebody who has lost consciousness. So which one we're going to give and what kind of instructions we're going to provide for the staff in terms of the rescue treatment. So green plus yellow for our rescue. And then the last part of this is red. So under what circumstances are we going to call for emergency transfer? Normally, we're going to do that if the meds don't work, or if you see the person is cyanotic, or if you see that their pulse ox has dropped significantly low, even when you administer oxygen. So here we look for a direction from the physician or the mid-levels in order to help us figure out, well, what is the maximum amount of time that we're going to have the person in the facility continuing to have seizures before we call for help, or if they have an unusual seizure, or if their seizure has caused them to sustain an injury, that is, for example, falling out of the wheelchair and fracturing, or if they're cyanotic. So this information is really on one full page. You can just Google seizure action plan and you'll see it come out just on one page. I just broke it up for you just for the ability to demonstrate it. So some of the keys for developing and implementing the seizure action plan include making it customized so that everyone is going to have a different seizure action plan depending on what their symptoms are, what kinds of seizures they have, what's been prescribed, and what are the limits that we're going to use in order to treat them in the facility versus send them out. So it provides the staff, as you could see, with really clear instructions: do this, then do that. It really takes out a lot of the decision making that have to be done because it's already been established. This is what we want to do. It's pretty user friendly, as you saw: green, yellow, red, and it provides these step-by-step instructions that are practical. Of course, you can tailor it as you need to for your individual or for your facility based on what other kinds of interventions you need to add. So the keys to implementing it are to use this standardized format, to download it and use it in the color version so people can easily identify green, yellow, red, and really in-service people on the use of it. And when I say educate, I mean all levels of people. It's really important also for nursing assistants to be able to understand what this is as well. We want to make it easily accessible, so if you want to keep a copy of it in the closet of their room, or in the chart, or in the hard copy of the chart, or wherever you think that this was going to be most useful, maybe in the med cart, be able to have it accessed, and you may need multiple copies of it. It can be updated and revised regularly when you're doing the MDS or when other issues occur that are going to affect that person's seizure threshold. So when you're thinking about implementing the seizure action plan, you may also want to consider what other kinds of disease states could be useful in a similar kind of action plan. So first, if we think about what barriers we would anticipate in the implementation and adoption of any SAP, we need to really get buy-in from the medical director, the medical staff, and the family, as well as the resident, in order to make sure that we are on the same page. We also need to have buy-in from the pharmacy and the pharmacy consultant in being able to help us identify who really could use an action plan. So I just put up here some other disease states that may really lend itself to formulating a similar kind of action plan, not just for seizures. So what to do when people are hyper as well as hypoglycemic, what to do when people are having an acute asthma attack or other forms of COPD, rather than sending people to the hospital. Are we going to do a nebulizer treatment? What will consist of the nebulizer treatment? How much time should we give that neb treatment to work before we do something? Are we going to use inhalers? Do we use multiple inhalers? What is it that we're going to do to address those kinds of issues? And you probably know that the use of sliding scale insulin is really going out of favor if it's already out the door in terms of diabetes, because it just doesn't seem to work, and we're actually treating the glucose that's already occurred. So facilities are really working with the physician and the pharmacist in order to identify the basal doses of insulin, and to be able to treat people rather than treating their blood sugar after it's already occurred. And then finally, what we're seeing in long-term care facilities across the country is that we have a younger population of people. We have people who may have opioid use disorder. We may have people who are getting outside medications or drugs from other sources. I was state monitor of a nursing home in Massachusetts that had half of the census were residents who had either alcohol use disorder or opioid use disorder. And they were very clever in how they got their drugs. One fellow ordered a pizza, and between the pizza box and the pizza were drugs. And he overdosed um, in the lobby. As soon as he got his pizza, he took the drugs. He didn't even eat his pizza. But you do see that people are doing these kinds of things, and it may be really helpful to an opioid overdose plan in place, so that the staff know stepwise what to do. And so, here are the references that I have, and I want to stop sharing this and then see if anyone has any questions or comments that they want to share with us.
Does anyone have any questions for Eileen today?
Well, let me ask you all, or seizure disorders a common thing that you're seeing in facilities? Is it something that concerns you? Do you find that these residents go back and forth to the hospital, to the ER, and you're wondering if there's a better way to deal with these kinds of issues?
Give them a minute, Eileen, just in case they are answering, in case they're typing it in the chat, because everybody is muted. If you'd like to be unmuted, you can raise your hand and I can unmute you.
So William said, we have not seen seizures as a common experience in our personal care home. I think that's probably good for you, but you may actually start to see these kinds of things, especially if your personal care home is admitting people who've had experiences with strokes or diabetes or people as they get older. So something to keep in mind, William, as time goes on, that perhaps this could be helpful for one or more residents in your facility.
Does anybody else have any questions for Eileen?
Well, if you do think of anything else, I'm happy to answer your questions offline. You have my email address, and I do appreciate you joining in today, and I hope that it will be of some help to you going forward.
Eileen, I want to thank you for joining us. Thank you to all of our attendees for joining in. As a reminder, we'll have those credits handed out when they're available. And this webinar will be made available on our website in a little bit today, a little bit later today. Eileen, thank you again. We appreciate your time.
Thank you.
Have a great day, everyone.
Bye, everybody.